Okay, hello everyone. My name is Brianna. I have a master's degree in social work, and I am going to be going over the content of today's simulation. If you guys have any questions as we're going, please feel free to drop them in the chat and let your facilitator know. And if anyone is interested in these slides, please let me know and I'd be happy to send them to you. This is a lot of information, and it's not expected that you guys are going to retain it all today. Today is really just a space to talk about substance use disorders and how we can be more empathetic as healthcare providers to improve patient outcomes. So our simulations objectives today are just to increase our general knowledge about substance use disorders and the physical processes of it, recognize the stigmas and how they can impact our patients, and in some cases even limit them from coming in to get care, increase our knowledge of different treatment modalities for harm, including harm reduction in patient care. And this one's really important because a lot of times people think abstinence is the main treatment modality for SUDs, and that's not necessarily the case. So we'll talk more about that today. And then also just practice working as an interdisciplinary team to come together and create a treatment plan for your patient. So that practice piece as well. I'm going to be talking about a few areas of consideration when working with clients who have substance use disorders today. And I want to iterate that this is by no means an extensive list of every consideration for working with this population, but I hope that overall we can just increase awareness for some treatment modalities. And if anyone is interested in furthering their knowledge in their practice, then this is a good space for that. Okay, so just a brief overview of what today is going to look like. You guys already did your introductions. This PowerPoint review is going to be about 45 minutes. We'll talk about your case for about 10 minutes or so, and then you will have 15 minutes in a team huddle. After that is over, you'll have 15 minutes in your patient encounter. When you guys come back to the main room after that breakout room with the patient, we're going to do a brief evaluation called the JTOG, where you answer questions about how you work together as a team. And then we'll get some feedback from our SPs and go ahead and do our team debrief, where we talk about the experience, what went well, what didn't go well, if anything, and then we will wrap up. So why are we talking about substance use disorders today? Why does it matter? When I was preparing this presentation for you guys, I included this quote because in my research of this topic and preparing this content for you all, I noticed that there's a pretty significant gap in education for our healthcare students. So I wanted to create a space for a dedicated time to talk about this issue. And the quote is from the American Psychiatry Journal about substance use disorders in education, where they found that over 60% of psychiatry residents reported feeling somewhat or extremely uncomfortable prescribing medications that are prescribed for substance use disorders. And there really just seems to be a gap in the curriculums for our healthcare students when it comes to this specific disease, which is unfortunate because it's a large part of the population. It is something you will absolutely see in practice. So that's kind of why we're talking about it here today. We're going to watch a quick video. Before the video, you may all have different degrees of background knowledge of SUDs, so this is just to review to make sure we're all on the same page.
Or when it gets addiction and substance use are often some people cause harm to society, but that's far from true. Many years of research show that substance use disorders are complex, chronic, and treatable medical conditions that involve changes in our brains. Researchers think it works like this. Our brains have what scientists call a reward system, behaviors that help us survive and stay healthy. Small increases in naturally occurring brain chemicals called neurotransmitters and parts of the reward system of pleasure. That helps explain why fighting into a fever, seeing someone you love smile, or learning something involved in social. Being engaged in new rewarding behaviors, the brain also builds connections between that behavior and related cues, like sights, sounds, or feelings that remind us of them. That's why just walking by a restaurant that smells good can make us hungry. And that's a good thing. This system motivates us to repeat behaviors that help us survive, such as eating, caring for each other, or honing new skills. Drugs are chemicals that mimic the neurotransmitters of the brain's reward system, but in many cases, use of drugs can affect the reward system more powerfully than other activities. For some of us, using drugs repeatedly can change the way certain areas of the brain work and each other. These changes can make it harder to enjoy healthy activities, and people sometimes start to use drugs to feel more okay. Suddenly stopping or significantly reducing regular drug use cause withdrawal symptoms that range from powerful negative emotions to life-threatening emergencies. Many withdrawal symptoms are treated, though for many, using drugs may feel like the only way to avoid. With repeated drug use, the brain may also build much stronger connections between drugs and cues associated. Cues that some people call this triggers, or people, places, things, and feelings that remind a person of using drugs that can make them really want to use them again. Repeated drug use can also weaken circuits in the brain that help people exercise self-control and tolerate stress. This can make it even more difficult for people to control drug use, even when it causes harm, when it doesn't feel the way it used to, or when it gets in the way of other parts of someone's life. These can be signs of a substance use disorder. While certain factors make substance use disorders more likely to occur in some people than in others, anyone can develop a substance use disorder, whatever their race and ethnicity, sex and gender, or economic status. Addiction can make using drugs or controlling drug use very difficult without support, no matter how much someone wants to stop or cut back. When someone tries to stop using drugs, strong associations between drugs and related cues and new or ongoing experiences of stress lead them to experience cravings and needs again. Returning to use after stopping or relapse is not uncommon, and like addiction itself, it's not a sign of weakness. While drugs can change the brain, treatments and time can change it too. People can heal from an addiction, especially when they get the support they need to relieve withdrawal symptoms, navigate triggers, and make positive changes. Researchers have developed therapies to support recovery, including safe and effective medications for some substance use disorders, like opioid use disorder. And because each person and brain is unique, researchers continue to learn more about how drugs and addiction work. They are always looking for new and better ways to prevent, treat, and manage substance use disorders in every person and every community. If you or someone you care about has a substance use disorder, you can learn more about getting help by calling the National Helpline at 1-800-663-HELP or by visiting findtreatment.gov.
Okay, so that's just kind of our preliminary video, that coupled with the knowledge that there's maybe not a curriculum or a space in a lot of healthcare professions, and that education isn't really available for substance use disorders. So here I would just kind of ask an open question, and no one has to answer. Excuse me. But maybe just something to reflect on is, do you feel like your education this far has prepared you to work with people who have substance use disorders? And do you have any biases that might impact your ability to care for that population? So if anyone wants to answer, I'll pause. I'll leave a space for your facilitator to pause the video to kind of reflect on that. But if not, that is just an open question. It's just something to think about as you're going through the simulation today. So yeah, now I'm gonna pause if anyone wants to speak to that, or if anyone has any other thoughts on the video we just watched, or questions about expectations for today's simulation before we get started. Okay, and now I'm back. So first, to better understand how we can be more empathetic with patients who have substance use disorders, first we need to do a brief overview of exactly what they are. So according to the American Psychiatric Association, a substance use disorder, the essential features of substance use disorder is a cluster of cognitive, behavioral, and physiological symptoms, indicating that the individual continues using the substance despite significant substance-related problem. So what does that really mean? As far as cognitive symptoms, that would look like things like poor judgment, impaired decision-making, impaired executive functioning, issues with concentration and focus, things like that. Behavioral would include things like social withdrawal, performance issues. It could be work, school, your personal life. Sometimes people have legal issues going on, secrecy or deception, risk-taking behaviors, things along those lines would fall into the behavioral category. And then for physiological, we have things like tolerance, withdrawal, appetite changes, neurological impacts, hormonal issues, overall physical dependency, things like that. So if you were to read the diagnostic criteria here, you would see a lot of those cognitive, behavioral, physiological symptoms that I just talked about. That's a lot of reading. I don't expect you to read it all on this slide. But what I do want you to pay attention to is there is a spectrum of how we would classify substance use disorders, ranging from mild, moderate, and severe, based on how many symptoms are present. So 2 to 3 would be the mild category, 4 to 5 moderate, and 6 or more severe. And this is a list of all of the symptoms that fit into that diagnostic criteria. So there are many classes of drugs that would constitute diagnosis of a substance use disorder. And I wanted to include this information in our presentation today because you might hear me say things like opioid use disorder or alcohol use disorder, and those all fall under the umbrella for SUDs. But sometimes you might hear people say the specific substance in front of the name instead of substance use disorder, or the acronym like I'm using SUD. So if this is an entirely new topic for you or just something you haven't dedicated a lot of time to, I like to review that because it's important to just make sure we're all on the same page and you don't have someone halfway through this presentation say like, what does SUD mean? So yeah, just some clarifying language for today. Okay, so I like to talk about the difference between substance-induced disorders and substance use disorders because it's kind of an easy thing to mix up, but there is an important distinction between these two categories. Substance-induced disorders are conditions directly caused by the use of substances, right? So we have some examples on the slide here of what that could look like. It could range from things like withdrawal, being intoxicated, sleeping disorders, and it could even be something more severe like substance-induced psychotic disorders, depressive disorders, anxiety disorders, and delirium. So I like to talk about prevalence because it's important to know that you will come across this in your career. According to data collected by the Substance Abuse and Mental Health Services Administration, we have approximately 20.3 million people 12 or older in the US who had a substance use disorder in 2020. The prevalence of SUDs can vary by age group, gender, race, ethnicity, other demographic factors. So for example, young adults, 18 to 25, typically have higher rates of SUD. And then it's also important to note that co-occurring mental health disorders are really common among individuals with SUDs, which can kind of complicate that diagnosis and treatment process. According to SAMHSA, the Substance Abuse Mental Health Service Administration, excuse me, in 2019, we had an estimated 9.5 million adults 18 or older who had both a mental illness and a substance use disorder. So we could definitely break down prevalence even further amongst certain groups and talk about how all this ties back to social determinants of health, but that would take a lot of time. I include this because I just want to emphasize that as healthcare providers, it's not a matter of if you will treat patients who have SUDs, it's a matter of when. So it's important to be aware of that and be prepared to serve that population. Okay, I'm gonna pause again just in case anyone has thoughts or questions so far, so that your facilitator can take a pause and now ask you that. Okay, and we're back. What is stigma? Um, so stigma is discrimination against an identifiable group of people, a place, or a nation. Stigma about substance use disorders might include inaccurate or unfounded thoughts like they're dangerous, incapable of managing treatment, or at fault for their condition. So, stigmatizing attitudes towards addiction can stem from outdated notions or misconstrued notions, as well as apprehension towards what is unfamiliar or what's not fully understood. Um, However, nowadays we understand and acknowledge that addiction is a chronic medical condition and it can be effectively treated. Um, it is recognized that individuals can achieve recovery and maintain fulfilling and healthy lifestyles. And I think that's important to address because stigma can have real world consequences that perpetuate stereotypes and lead people who use drugs to avoid treatment altogether. So it's important to acknowledge the stigma and try to avoid using stigmatizing language so that we don't accidentally lead someone to avoid treatment or just feel ostracized while they're getting medical care. So I included these examples of ways that language can be stigmatizing, and we're going to go over some of them. I want the main takeaway here to be that we don't want to assign morality to drug use, right? Because there are healthy ways to use drugs and there are unhealthy ways to use drugs. So we want to be as medically accurate as we can and avoid using language that makes patients feel ostracized or like they're failing because it can cause them to internalize that language and maybe even avoid treatment. So as I'm reading these examples, I encourage you to think about how you could potentially apply some of these changes in your patient interaction today. So the first one, person with a substance use disorder, person with an opioid use disorder, instead of things like addict, user, junkie, just because we want to use person first language. And it also is like validating to classify SUDs as the illness that they are. And it's just important to use that language that shows that a person with an SUD has a problem versus them being a problem. And same line of thinking with person with alcohol use disorder, person who misused alcohol, engages in unhealthy hazardous drinking versus alcoholic or drunk. It's the same kind of line of thought there. Person in recovery or long-term recovery versus former addict or reformed addict. That language avoids eliciting negative associations and individual blame. This one is really important. Testing positive on a drug screen instead of dirty or failing. It's just, this one is important because it's critical that we use medically correct terminology. We want to be medically accurate. If someone came in for an STD panel and they tested positive for that STD, we wouldn't say that they failed. So we just want to be as medically accurate as we can. Substance use disorder or drug addiction versus habit. Once again, kind of validating the illness and it undermines the seriousness of the illness when you describe substance use disorders as a habit. And then we have use versus misuse and abuse. So we don't want to use the word abuse because again, it has that high like association with negative language and it kind of assigns that morality to drug use. So use is for illicit drugs and misuse would be for prescription medications that are being used incorrectly. Once again, instead of saying clean, we can say things like being in remission or recovery, abstinent from drugs, testing negative, just because the opposite of clean is dirty. So we just want to be aware of like the implication of that. And excuse me, and once again, we want to use just medically accurate terminology. And this one is important because babies cannot be born with addiction. Addiction is a behavioral disorder, so babies by definition cannot have it. So we don't want to say things like addicted baby. Instead, we want to say things like baby who was exposed to substances, baby with neonatal abstinence syndrome, baby born to a parent who used drugs while pregnant, things like that. It's just, this is another one where it's just kind of a reflection of medical accuracy. Okay, I like to review that because there are some easy language changes that do make a big impact. So saying person who uses drugs versus drug addict separates the person from the drug use, and it's like who they are versus what they do. So I just think it's important to review that. So while we're still in that line of thought, I also want to say that several professions collaborate to help individuals with SUDs, and this field is constantly evolving. And it's really, really common to come across research or providers who work in the field that still use stigmatizing language. Even amongst people who work with people who use drugs, like that's what they do, stigma and discrimination are still really present. So being thoughtful with your language is one way to build rapport with your patient. And you can always ask what language is comfortable for them. I think sometimes people who use drugs make other people uncomfortable, and the topic makes people uncomfortable. And you can't always engage in that best collaborative care with your patient when you're afraid to address the things that make you uncomfortable. So I've talked in my like creation of the simulation and work I've done in the past, I've talked with people who work in this field, and I actually have talked with someone who is a director of a nonprofit who doesn't like the clinical language. He prefers non-clinical language. Um, he's even used a spectrum when working in the nonprofit sector where he would ask his clients to classify their use as chaotic or non-chaotic, because he feels like that clinical language kind of he's had an SUD himself, and it kind of makes him feel like a set of symptoms instead of a whole patient. Um, so yeah, obviously in this setting, we're using those terms because it's an educational setting and we need to be able to assign meaning to things. But all of this to say, just ask. Just ask your patient what's comfortable for them, what language they like or don't like. That's okay to do. And I think it'll actually be helpful in rapport building. Okay, so this section discusses older adults because it's a population where substance use disorders can unfortunately go undiagnosed and untreated altogether, because older adults are not necessarily who you think of when you think of addiction as you know it. We're not really thinking of like the grandmas and the grandpas when we think about this demographic, but they are a part of this demographic. So our case today is actually an older adult, and part of your job will be to ask questions to identify some of the signs of drug misuse and talk to them about what healthy use is. So prescribed medications are more common among older adults in comparison to other age groups, and older adults are more likely to unintentionally misuse their prescribed meds. So 17% of older adults have misused prescribed medications. That's not to say that all of those people will develop substance use disorders, but it is to say that it's important to talk about how people are using their medications with them and look at things like medicine reconciliation, um, and just have that on your radar, especially when you're working with older adults. So older adults have different treatment considerations than other populations. For example, when would you consider inpatient treatment looks different for older adults than it does other adult populations. So older adults meet the criteria for inpatient services if they meet criteria for SUDs, have co-occurring health and mental health concerns, which, like I said earlier, is really common in SUDs. We're very rarely just treating an SUD. It's usually going to be co-occurring with some other mental health issue. If they need medically supervised withdrawal, or if they chose abstinence as their primary treatment goal. So older adults have several considerations when we're treating SUDs. There are also considerations for older adults going through withdrawal. That would include, like, older adults are more likely to experience delirium. Withdrawal symptoms may be less detectable, but they last longer than they would in younger people. Withdrawal may worsen other medical issues they have going on. They're at greater risk than younger adults for alcohol withdrawal related medical and neurological problems. And you also have to consider how withdrawal might interact with medications that the client or the patient is on for other conditions. So, yeah. There are medications available to treat substance use disorders, and we'll talk about that a little more, but in older adults, a PCP or another provider would need to ensure that there's no interactions with other medications they're taking, and that's also where pharmacy would come in. Older adults are less likely to get referrals to specialized SUD treatment from healthcare providers than other groups are. And it's also important to think about how specialized treatment might look like inpatient or like something like group therapy. And for older adults, they are more likely to benefit from age-specific treatment with individuals who share age-specific commonalities. So in some programs, research showed positive outcomes in 60% to 85% of older adults who participated in age-specific treatment programs. And part of the reason for that is because those age-specific programs have considerations for things like hearing aids and visual aids, and also they're able to talk with people about the phase of life that they're in, so they might share commonality in grief and their loss of friend groups, or how their families are changing and evolving as they get older, and things like that. Okay, so these are some reflection questions. I am actually I'll read them out loud, and then I will pause to let your facilitator go over them with you guys, and then you can come back and finish the lecture. So the first reflection question is, there's a common bias in medicine against people who are presumed to be drug seeking. However, when working in geriatrics or with older adults, our biases about people who use drugs may inhibit identifying the signs of substance use. What are some ways that you can reduce these biases? And I'll pause to let you answer that. And then the next question, hi, you're back. The next question is, as we have discussed, there are specific considerations when working with older adults who use substances. Do you know of other populations with specific considerations? And we'll pause for that too. Okay, yeah, you've answered the question. So hopefully some of you identified some other populations, but here are some in case we weren't able to. Pregnant people are important to consider. Adolescents, indigenous populations, women. Women specifically are less likely to be diagnosed with alcohol use disorder. So that's an important consideration when you're thinking about that. I wanted to highlight the older adult population generally because I wanted to show how in treatment for SUDs, the treatment modality is not cut and dry at all. It will and it should look different for everyone because everyone has different recovery goals. And for example, with older adults, they have entirely different considerations, and that's true for other distinct populations as well. So older adults in this lecture are kind of being used as an example to highlight that treatment does not look one way for this disease. These are just some overall provider takeaways. Like we've been over this a couple times now, but SUDs commonly co-occur with other mental health issues. You're very rarely just treating one or the other. And I want to highlight this last point, respecting the client's autonomy and asking what their health goals are and really just collaborating with them on that. Not everyone seeks abstinence, right? That is a personal health choice, and sometimes it's one that providers have a hard time accepting, but recovery does not have to look like abstinence. We'll talk more about treatment and harm reduction, but I think it's important to emphasize that if your patient's goal is to reduce their use, then that's also a valid choice, and that's a choice that they have the autonomy to make. So in this section, we're going to talk more about what treatment modalities are out there and what harm reduction is. So I'm going to read this quote about what harm reduction is. It's kind of long, but I think it's a good definition. It's an important definition. SAMHSA defines harm reduction as a practical and transformative approach that incorporates community-driven public health strategies, including prevention, risk reduction, and health promotion, to empower people who use drugs and their families with the choice to live healthier, self-directed, and purpose-filled lives. Harm reduction centers the lived and living experience of people who use drugs, especially those in underserved communities, in these strategies and the practices that flow from them. So, harm reduction is a framework, and it upholds that any mitigated potential harms to people who use drugs are a success. For example, if one patient experiences an overdose, but we provided them with the knowledge of what Narcan was and provided them with Narcan that was able to reverse that overdose, then we have successfully mitigated that harm. For those who don't know, Narcan is an opioid antagonist. It can reverse opioid overdose, and it is a nasal spray that you can administer to someone in an emergency. But in this disease process, relapse is unfortunately usually the rule and not the exception, and people can't recover if they don't survive. So dead people don't recover. So I really love this definition because it kind of highlights that the practices of this harm reduction framework and the things that we have come to know, like, hey, this is what works and this is what's helping these communities, has directly come from them. It's things that they've done and they've tried and they say, hey, this is actually saving lives and it's really helping us. So yeah, I think it's just a great framework and it's a good way to see what's actually worked from people's lived experiences. Okay, so we have some more reflection questions here. I'm going to pause again, let your facilitator pause so you guys can have a little discussion. So let's talk about, has anyone heard of harm reduction before? And if you have, do you know of any examples of harm reduction in the real world? And we can pause for that. Okay, so hopefully you guys talked about some examples of harm reduction in the real world, but if you didn't, that's okay, because we're going to go over some now. The first, we have needle exchange programs. They reduce the risk of transmitting bloodborne infections like HIV or Hep C. We have things like supervised injection sites. They're also sometimes called safe injection facilities, and they just provide a safe, hygienic environment for individuals to use drugs under medical supervision. They're not very popular in the US. To my knowledge, as of right now, there's only maybe one or two that are active in the US, but they have been implemented in other countries, and they have actually been able to do longitudinal studies of that show that there is a reduction of overall overdose deaths in those areas that do have safe injection sites. And also, a lot of times there is an overall reduction of people who are using drugs overall in the population. So that's interesting. We have opioid agonist therapy. That's basically using medications like methadone, for example, to treat opioid dependence. And medications like that can help reduce withdrawal symptoms and cravings. And it kind of just allows individuals to stabilize their lives to reduce their use of illicit opioids. It's usually done concurrently with mental health treatment as well. We have naloxone distribution programs. It's another kind of harm reduction. Naloxone is also sometimes called Narcan. It's, I think I talked about it earlier, but it's a medication that can reverse opioid overdoses. Education and outreach programs is a form of harm reduction, just providing education about safer substance use practices like using sterile equipment, um, avoid mixing substances, recognizing the signs of overdose, things like that. Um, Drug checking services or fentanyl test strips. It's where you take a small portion of the drug you'll be using, mix it with water, and you can put that test strip in. It's kind of like a pregnancy test. If it has two lines, then it's positive. You know it's positive for fentanyl, and you wouldn't use that. And then things like safer drinking drug use guidelines kind of fits in with that public education aspect as well. So, like I said, harm reduction is a framework, so there are many, many, many things that fit into that framework. So these are some examples of that. Okay, so medication for opioid use disorder, also a lot of the times I most commonly hear it referred to as MAT, which is medication assisted treatment, but it just refers to the FDA approved use of medications to treat substance use disorders. Um, and these are examples of some of the medications that are used to treat substance use disorders. And you can kind of see how they block the opioid receptors differently, or if they don't block them, then they might generate that effect. Um, so yeah, they basically just work to suppress withdrawal symptoms and reduce cravings, um, so that people can reduce their use of illicit drugs. And I also believe there are medications for alcohol use and nicotine use that work similarly depending on the nature of the drug. They just might block the pleasurable effects altogether or reduce cravings, depending on the drug and the substance. Okay, so there are a plethora of treatment modalities for SUDs, and unfortunately, we can't go in depth on all of them today because we just couldn't do them all justice in the time that we have. This is a baseline list of options that are out there, and I really just included them to put them on your radar. We have things like behavioral therapy, group therapies, peer support specialists, which is someone who has had an SUD themselves, working as that support specialist with an individual. AA or NA, which are faith-based groups, which is Alcoholics Anonymous and Narcotics Anonymous, if you've never heard of them before. Something called motivational interviewing, which we'll talk a little more in depth about, but I really want to put that on your radar if you're interested in working um, with people who have substance use disorders specifically. Um, Motivational interviewing is a great tool, and anyone can do it. Anyone can learn to do it. If you're interested in working with this population specifically when you're out in the field, look up motivational interviewing and try to learn a little bit more about it. I highly recommend that. Um, where was I? Sorry. Lastly, treatments are not one size fits all. So it's important to talk to your patients about how to approach their care and what their health goals are. Um, so yeah. And briefly, just to go back to MI, I don't really think I said what it was, but MI practitioners kind of collaborate with their patients to elicit and support their internal motivation instead of pushing their own ideas or solutions. Uh, Motivational interviewing, or MI, it's a brief intervention and it's usually done in like one short session with a patient. So this treatment modality, SBIRT, is an acronym for screening, brief intervention, and referral to treatment. It is an evidence-based approach to identify individuals who use alcohol. Um, Originally, it was used just for alcohol, but it can also be used for other drugs or substances. So to identify individuals who use at risky levels. SBIRT has been shown to be pretty valid and reliable in identifying and improving outcomes for people who use substances. And the goal of SBIRT is to prevent or reduce the use of substances to prevent health-related consequences or disease or accidents. So it's basically, it's kind of a public health intervention, and it's kind of an early intervention approach. combined a little bit. So I want to talk about this treatment modality specifically because anybody can do it. It's a skill set everybody can learn. I don't expect you to be able to do this today in your patient interaction because that would be impossible if you're just hearing about it. But it's another thing I wanted to put on everyone's radar. Espert was first used more for alcohol, but it can be applicable to other substances as well. So in those cases, you would just change the screening tool to reflect whatever substance they're using. So the traditional screening tool is called the Audit C, and it's for alcohol. And I'll show you a picture of what some of those questions look like in a minute. But basically, you give the patient the screening tool, or you can go over it with them verbally. And that screening tool will give you a score. Based on that score, you'll be able to put them in the mild to moderate category or the severe category. In that mild to moderate category, you're going to do a brief intervention where you talk about their use, you talk about what healthy use looks like, what a healthy amount of use looks like, and just give them health information about how it could impact their health later down the line. If they are in that severe category, that is when you would refer to treatment. Okay, so this is the Odyssey I was talking about. This is not the full one. The full one has more questions on it. This is a shortened version. But basically, they answer these questions, and then based on their score, you'd be able to put them in those categories we just talked about. So the questions are things like how often you have a drink containing alcohol, how many standard drinks do you have containing alcohol a typical day. You'll notice at the top that it has different drinks and different amounts. And I think that's so important before you give your client the screener to go over with them. So 12 ounces of beer would be 1 drink, or 8 to 9 ounces of malt liquor, or 5 ounces of wine, or 1.5 ounces of hard liquor. And it's important to kind of clarify what 1 drink means to them before they fill out the screener, so that we're getting the most accurate answers that we can. For example, if someone self-reports to you that they're drinking 1 glass of wine a day, but it's a huge like 12-ounce glass, then really they're having more like 2 glasses of wine a day. And so it's just important to make sure you're on the same page before you administer something like that. So based on the patient's score from the full screener, it would categorize their use as one of these categories. We have high risk, harmful, risky, and lower risk. And you can talk to them about what each category means for them and their health. And one cool thing about Esper is it's really customizable to the patient. So based on what they're telling you, you can give them information that's suited to them and their needs. So if they're in that risky use category, that's a great opportunity to say, hey, you are technically in this risky use category, because people in that category usually don't realize that the amount that they're drinking can be detrimental to their health. So it's a great opportunity to kind of do that harm reduction model and say, hey, here's this education about your use and what a healthy limit is for you. And it's not to scare the patient, but it is a way to say, like, here are the very real implications it could have for your health down the line. Is there a way you'd be more comfortable drinking within this lower risk category, where we could reduce your drinks to this amount a week that would be healthier for you? Okay, so this is, we kind of already went over that we should be on the same page about what a standard drink is before they take the screener. This is a card. It's that you can print off front and back. The front is actually this page here with the risk zones, and this is the back. So this is helpful if you just have some of these printed out in your office to use as an educational tool to give to your patient so they can kind of visualize some of the things you're saying to them. And it's helpful to be able to point and say, you fall in this category because you had this score. Um, and to point to the drinks and say, this is what a standard drink looks like depending on your drink of choice. So it's just a good educational tool to have, and it makes it a little easier on the provider too when you have something to refer to say, this is what we're talking about. Um, I think education is a really important part of ESPER, and a lot of patients don't actually know what constitutes one drink. So it's just important to share that. And this visual can be really helpful for that brief intervention piece. Okay, so that is all of the lecture that we have for today. I know that's a lot of information. Hopefully, some of it was helpful to you. Hopefully, there are some things that you can take away and use in our simulation today. Um, like I said earlier, if you're interested in working in this field, I really recommend you look further into motivational interviewing, or MI, and SBIRT. That screening, brief intervention, and referral to treatment. Those are two treatment modalities that I think um, anyone can learn, and it'd be really helpful to you in your practice if that's a field that you want to work in. So now we're going to go over today's case. Your patient today is Alex. Alex is 68, and Alex is a retired factory worker who has recently lost their spouse of 40 years. Since their passing, Alex has been feeling increasingly lonely and depressed, and to cope with their grief and depression, they have started using prescription opioids more frequently and in larger amounts than before. What began as occasional use for managing pain has escalated to daily use beyond prescribed limits. Alex's family has noticed changes in their behavior, including mood swings, isolation, and neglect of self-care. However, they attribute these changes to grief and aging rather than recognizing them as signs of a potential substance use disorder. So your job today is that Alex is coming for their annual checkup, and as a team, you're going to decide how you want to approach Alex's care. You want to create a health plan with the patient's goals in mind, ask them what would work for them, and you want to create and maintain a culture of respect between patients and all providers. And consider some of the things we talked about today. Consider the harm reduction framework and the language that you're using, and how we can avoid stigma. Yeah, so now I'm going to turn it over to your facilitator and let you guys practice. Good luck, and I hope that you learned something and you're able to take something away from this experience today.